It's too nice, Wayne. Very, very nice. Thank you very much for your attention today. I'm going to talk a little bit about platelet-rich fibrin matrix and how it's different than PRP and its uses in at least possible uses in DFUs. And then if we have some time, we'll kind of go into some of the new emerging technologies that are out there right now. Okay, so here's the outline. So what is PRP? How do you make PRP? What is PRFM, so platelet-rich fibrin matrix? How is it different from platelet-rich plasma? And we'll review some new clinical data on PRFM, which I'm very excited because this is the first time that I'm actually reporting on data which is soon to be published. Okay, so here's whole blood. And if you see, our platelets are pretty meager. There's less than 1% when you combine it with white cells in terms of whole blood, and plasma is 55%. Why do we need platelets, or what do platelets do? So these are small granulating bodies. They live for about a week, produced in the bone marrow, and they're stored in the spleen. And they're involved in the initial phases of wound healing, which is what we're concentrating on today. It has calcium and potassium, some clotting factors, and growth factors, which we will discuss. So in plasma itself, what is plasma? Because it's the fluid portion of our blood, which contains proteins and some antibodies, some clotting factors. It's about 5% of our body weight. So plasma clots on standing. So if you leave it alone, it will clot. And you need to add an anticoagulant to whole blood if you want to harvest the plasma. What do platelets do? They're involved in hemostasis, as we know. Cut yourself, hemostasis. It creates a scaffold for other cells to kind of bind to, some growth factors, and again, allows for some stem cell binding. So, we use this word PRP very frequently, but what is actually a PRP? Is there a definition of what is platelet-rich plasma? So PRP is it's a preparation of platelets in a limited volume of plasma. Depending on how you harvest it, you can get about 3 to 5 times platelets and growth factors per volume of plasma. It depends on how you concentrate it. But there's really no data to show that one version of PRP is better than another, meaning that if you have 3 times platelets in your plasma, that it's not as good as 5 times platelets in plasma. There's even controversy of whether you have PRP, whether if you have white cells in it or you don't have white cells in it, does it really matter? So the jury's out, and for all intents and purposes, if you have more platelets than normally in whole blood, 3 to 5 times, we will call that PRP. So when you look at PRP, so let's look at a normal blood smear. It's actually these small little things here. These are platelets right here, right? And when you have PRP, you have a little bit more, okay? So that's what we're looking at in the blood smear. When the platelets are resting and they're not activated, they look kind of like round, flat, clear nothings. When they start getting activated and doing jobs, you can actually see how they make this mesh of like tendrils that come out from there as well. Now, as you increase platelets, right, you're also going to increase growth factors. So there's an increase. So there's a linear relationship. So, which is what you really want to say is the more platelets we have, the more growth factors we have. So, right. Why do we need growth factors in wounds here? So one is it's chemotactic, right? So you're gonna call people over. It's like the growth factors are like your best friend at a bar, and he knows all the cool people in the bar, and he kind of calls them over. There's migration, where the stem cells are now attracted to this area of damage. It allows for proliferation, which will dividing cells in response to this stimulus, and also platelet signaling. Again, kind of that same thing where the growth factor now then binds and then calls more cells over. So growth factors are very, very important to that. And again, stored on platelets, the more platelets we have, therefore the more growth factors we have, and the more activity we're going to have at that center. So that is the theory behind why we're going to try to get these into a wound. Right? What are these growth factors that are in the wounds? So there's a bunch, but let's call it 3 major ones, which we look at is PDGF, TGF-beta, and VEGF, and they all do very particular things within these growth factors in PRP, and they're highly concentrated again in PRP, 5 times the amount, 3 times the amount, 6 times the amount. So there's more of them in PRP. So how do you make PRP? So the first thing is you need to stop clotting of the whole blood, right? And the way that you do that is by binding this ionized calcium with citrate. Okay? Then you spin it out. And then this yellow thing here is the platelets in their plasma. There's a buffy coat, and then there's red cells down here. And sometimes you can actually use a second spinning cycle if you want to concentrate it more. So there are some systems where you'll take 8 to 10 cc's in a vial, and then you'll get a yield. And some of them are like complete vampire systems where you'll take 60 cc's of blood, and then you'll get 3 cc's of yield afterwards. So it really doesn't matter what you're doing. It's just every system's a little bit different, okay? So this is by far and away the most important thing. How do you prevent premature activation? So when you activate these platelets, the growth factors just kind of come out. They get squirted out, and they just keep going, right? You can't really stop them. Once it starts, it stops, right? And so they're released within an hour. All of them are released within an hour of an injection. And you can activate this either by exogenous thrombin or by touching it to collagen, right? So what's the difficulty of using PRP in wounds? I just said it's awesome, right? Why wouldn't you want to go ahead and do this, right? So one is, it's a liquid, right? It's very hard to keep that liquid where we want it to be, especially in an open wound, right? How's it's going to kind of like go wherever it wants to go, right? The other thing is that in order to combat the fact that it goes all over the place, we'll add thrombin to it in order to be able to hold it. Well, what we say, if you add thrombin to it, basically all the growth factors are excreted in 1 hour. So we want to do. So how do we combat that as well, right? They also again live for a very short period of time because they're rapidly reduced, and you may get oversaturation at a tissue receptor, right? If you have 10 seats at a table here, right? At 10 chairs, there's only 10 people that can sit here, right? But what if we have 100 people waiting outside? Well, it doesn't really matter for the rest of the people that those chairs are already filled. So if you oversaturate those receptors right away, then everything else kind of hangs around outside and doesn't do anything. So in a solution, something that's kind of elegant solution, a platelet-rich fibrin matrix is something that can solve for some of these problems, right? So it acts as a scaffold. The matrix acts as a scaffold. It doesn't have any additives to help for the coagulation, and it forms a natural fibrin clot. And as it starts to repair itself, it starts to recruit more and more cells, which start to build collagen. Platelet-rich fiber matrix also has mesenchymal cells, which can help regenerate tissue in that area as well. And it has a high level of growth factors, right? So how do you make it? You make it through these steps of centrifugation, and you also add calcium chloride to it, but no thrombin. And when it's done, you actually have something that's suturable, or you can affix it with steri strips. The first spin is 6 minutes, and that you'll get out the standard PRP. And then what you do is you add it into a bottle that has calcium chloride, and it's spun at a very, very high level at 25 minutes, and it'll give you this matrix. Now, there's a reason why this is kind of resurging. A lot of you are thinking to yourself, didn't I do this earlier in my career, like 25 years ago? And the answer is yes. I remember when I was training with Wayne, this was the coolest thing around, right? We used to do that, exsanguinate the patient, make these things. It took us hours, and then we would suture to this stuff, and it's what we had. We basically were making our own tissue grafts here, and it was like science fiction. Like when you saw it was the coolest thing in the world. So then why is it making a return right now? Well, a lot of it has to do with the fact that some of the tissues which we used to use that had growth factors, like umbilical cord tissue, which is now highly regulated, and in New York we can't even get access to those types of things anymore, which used to have a lot of these kinds of growth factors on there, and it was a mainstay of a lot of my treatments. I don't have that anymore. So I needed something that had bioactivity in order to be able to help the wounds, and this is where I kind of went back to try to bring back some of the old things and maybe see if it can help us and fit a gap. All right, here's what the kit looks like, right? So you have this venipuncture and a couple of things here, and then you draw it out and you put it in this, and then you make this thing. So here, you venipuncture, then you put it in a vial and you spin it down again, and it makes this. Have any of you used this in the past? I mean, I would say the older practitioners may have used this in the past, but probably not newer ones. So it makes this this graft. And this is all this is made from platelets. There's really nothing else here, and calcium chloride. And you can suture it, or you can use steri strips. Again, so what's the comparison? So here, you adding thrombin from the PRP, and in this case, for the fiber matrix, you don't do that as well. I'm going to go buzz through this, but basically, there's an in vitro study that was done by O'Connell, and then looked at, are we actually getting growth factors that are sustained over time, or are you getting everything in one shot? What he did is he washed things out. He washed these media out with saline at certain time intervals to see, are there more growth factors that are growing over time? And he found that as you do this, there's this cascade that happens which mimics what normally happens in the body. So it's not like it's carrying over from day one and then everything you get is from when you spun it. It actually mimics what's going on in the body, where certain things are upregulated at certain times. Okay? And that the clot actually, the matrix is actually stable after a week of eluding these growth factors. Okay. So this is a study that was done by that same group looking at VLUs, and it's an older study, but this is where I got a lot of my kind of reason to kind of extend this out into diabetic foot, because they didn't have any data on that. So this is how it comes. Where you get this clot, and then the matrix, then you kind of put this on and suture it. They looked at VLUs. Some of them were not VLUs. And they had a pretty large ulcer size with a pretty large range, and they found that they got closure in venous ulcers of about 65%, and 75% achieved closure, about 75% closure in those who responded. So the people who responded actually responded well. It took about 7 weeks to close, and about 2 applications per patient. It was much slower in the VLUs, right? It was a smaller group, but it was smaller in the non-VLUs. So here are a couple of cases with these multiple VLUs. This is a single application which closed in 3 weeks. Again, application of that matrix. Here's an 85-year-old with 3 applications of a VLU. Here's a 44-year-old with a traumatic wound, and 2 months later it was closed here. This is really the exciting part for me, obviously, because I did this clinical trial. So we looked at how is this going to work in diabetics, okay? There were 25 patients screened. There was a little bit of a higher number of failures. I kind of rounded out to 20% failure, and it was a little bit higher than that. 18 passed the screening, 8 healed, 6 didn't heal, and 4 were removed from trial for some random reasons. So in the final cohort, I had about 14 patients. Again, not a large cohort, but again, for proof of concept, this was enough. So we looked at how many closed within 12 weeks was 8. Of the 6 which did not close, 5 of them had a reduction of 50% within those 12 weeks. Only 1 of them did not have a closure of less than 50%. But then when we looked at the analysis afterwards, we were able to give some predictive value, meaning that the 4-week mark really was indicative of future closure. So if you closed by more than 50% at week 4, you had a much higher rate of closure at week 12 than if you didn't close by 50% at week 4, you weren't going to close. So one of 2 things happens there. Either you have to say to yourself, you have to do a reapplication, which could be that, could just be the environment of what's going on, or that you have to do a paradigm shift. There may be something else that's going on that we're just not ready for something like this yet, right? Whether there be local issues going on, there's systemic issues going on, but really, anytime you use some type of a technology, there has to be a rein on that technology, something that holds you back, where you don't say, oh, it must be the technology's issue, it's not my problem. So any time you do this, you have to say to yourself, what's the expectation, and when should you have some kind of a response? And in any of the studies I do, I always look at a responder rate, and can I see if there's some kind of of distribution where at some point in time when we're doing the study, we can already predict that the thing's not going to go in the right direction. So I can tell these patients now that I know if we don't get a 50% response at 4 weeks, we have to do something else, right? And this is like a blanket statement from anything else that we do. So again, just to kind of isolate some of this, so 8 of these patients closed among the entire cohort. 10 of the patients had a 50% reduction by week 4, and 4 of the patients had greater wound reduction by 50% at week 12. Why use this over some other CTPs? One is its cost, right? It's your own, basically it's the kit. There's no tissue that's being made except from your own blood, so that's pretty good. So I'll just tell you, it's about 25% of what some of the regular tissue-based, these cellular and tissue-based products are. Availability, you got plenty of blood. You can't really be allergic to yourself, which is although being allergic to any of the collagen products is rare, but it can happen. But I get this all the time. Doc, I do not want cows, sharks, pigs, bladder on me. I don't want that. Is there anything else you can do? And this is something you can offer. I will tell you that when you're dealing with deep wounds, this is not the therapy for us. This is for something where it's a stalled wound that's on the Wagner grade 1 level, maybe inching to grade 2, but this is not for depth. It doesn't have the consistency that you want to do something for that. Okay? Thank you very much. I appreciate that. And if it is okay, yes, I'm going to be able to go into my next lecture, which is short. Fortunately. Before 2. Oh, yeah, definitely. I even have time. Please. Okay. Do you mind calling up my other lecture? Is that okay?